mean, first of all, I'd just like to thank you very much for inviting me here today. And I want to congratulate SKC for organising this conference. I remember I was fortunate to attend the very first one in London 6 years ago, and I think this is, a major achievement, and it benefits everyone. And the greater the involvement, the greater discussion with parents, the greater discussion with people around the world, the better. So thank you very much indeed. So just give a couple of sentences about my personal situation. Right. So about 5 years ago, I became very ill, and I haven't had the privilege of seeing a patient for the last 4 years, and I retired 3 years ago. And virtually every morning I wake up, I wish I'd done more for children with neuroblastoma. So in my retirement, I'm trying to do what I can, which is limited to try and help children with neuroblastoma. And very much that what I'm going to express today is my personal kind of views. And I'm asked for what's my view on this, what's my view on that. And although not a key leader, I can actually give my personal view. So that's kind of my background. Now, there were 29 questions submitted, so I've done my very best in 30 minutes to answer those questions. And I've tried to leave some time at the end for some answers to those questions. So, with Nick's advice, so I got these 29 questions, and I thought, what on earth am I going to do? So I emailed them to Nick, and Nick gave me some very good advice, which I'm following, and that's actually to divide them into 4 groups of collaboration successes, a couple of questions about what is neuroblastoma, about treatment, and some general questions. And first of all, just 2 personal comments. I mean, I feel even more so now that I've retired is that we must accelerate and make faster progress. And we have these ideas, and which are all good ideas, but we are, I think, far too slow in actually getting them to the children who need them. And the second thing is that we've got to have this balance. When you see a child in clinic, you've got to do the very best for that child, but you've also got to think what's best for tomorrow's children. So these are just 2 overriding thoughts. Now, the first group of questions relate to collaboration and successes. So just to make sure everyone's on the same page, in Europe there were 3 groups, the GPOH from Germany, the Netherlands group DCOG, which is people tend to forget Netherlands. The Netherlands are very strong in terms of science, despite their relatively small population, and the Siap group, which involves other countries, Israel, Hong Kong, and Australia, outside Europe. And then there's North America, the COG, and the Japanese group. So, I mean, the first question is, how do the study groups, Siap and Cog, work together to plan phase 3 studies? So, that for about 10 years now, there's been interaction. So the COG leader, who currently is Julie Park, attends all the Siap and vice versa. Dominique Valtucuno, who's the leader of Siap, attends the COG meetings. And at the moment, I think that COG and COG have never been so closer. They've both done a superb job in bringing the groups together. And each group knows and comments on the next phase 3 trial. So, I mean, Julie Park saw about a month ago, or less than a month ago, the Siap plans, and she commented on them. And our general aim is not to learn maximally quickly, and if we can ask different questions, but in a planned way, we can try and do that. So, for example, as we've heard, that MIBG is being looked at in frontline in COG, in Siap it's being looked at relapsed in the Veritas study. The hypothesis that we have is that the BUMEL is equivalent to the current COG tandem, and that is trying to be tested in both sides of the Atlantic in a different way. But, however, because of Wayne Furman's and Rajan Moody's really exciting results on combination of chemotherapy to immunotherapy, both groups want to really look at this at the same time. Now, we've already sort of touched on this in Giuseppe's talk, but I think in terms of collaboration, we've collaborated for 10 years and discussed phase 3 studies between Siap and COG. But in terms of early stage studies and what are people's ideas for new drugs, we've never done this before until September this year. And what was, I think, an excellent step forward is there were European and US experts, the leaders in drug development for both countries, and not just the clinical aspect of the biology, met together in Cambridge. And there was a very honest and open discussion about what's best and trying to plan out how things are going to go forward in a coordinated way in the future. And also important, we had, as Giuseppe said, we had pharma there. We also had patient representatives, Guy Blanchard and Nick. And the key element is that we need to have a phone call in the next month to keep this going. And every group is committed to this dialogue going forward, but it's really important that it happens. So the next question, how did GPOH decide to join Siap? So quite a few people have mentioned, I totally agree with, I think there's a major step forward. And the joining has happened because of 3 reasons. And first of all, together, we've got more patients so we can do quicker trials and get quick answers. The second thing is we're combining experts and resources so that, Rupert Hagener, Holger's expertise in immunotherapy, Angelica Eichhardt's expertise in target, they can all join together. So the experts in Europe will all be working together. And also there's a critical mass aspect. So something that we want to do, but we haven't had the resources to do it, we can, and relapse is particularly important, treatment of relapse, we can now get on at a quicker stage to do it. So I think it's an important step forward, and the aim of doing it is to making faster progress. And as I mentioned before, we mustn't forget the Netherlands, and I think their scientific input is really great. I was talking to a very good friend of mine who's an acute leukemia expert about 2 days ago, and I said, I'm frustrated because we are so slow. And he said that in acute myeloid leukemia, he felt one of the reasons that they were slow was because there were 6 European groups. So I think, neuroblastoma has moved on, and at least there's only one now European group, which I think is very good for the future. So I'd like to spend a couple of seconds about, again, why did the GPOH decide to join Siap because of the relapse approaches. So I think both groups said, we've got RIST and Beacon for initial relapse, but we need to have something to follow on. And because of pressures, it's not been delivered yet. However, we had a meeting in Cambridge again in September, and the agreement was that we would have common approaches for today and for the future. So GPOH and Siap, their approaches at the moment are like this, and they will, over the next couple of years, diverge. And the idea is to have a treatment package and options which will be available across Europe. And I think one particular thing is the role of haploidentical transplant will be a part of that package. So we'll be able to answer the questions, in a bigger number, which group of patients benefit maximally, those kind of things. So I think this is, another major effect of the 2 groups joining. The next question was, is there a possibility of Coggan and Siap working together in a single study? I think definitely yes. It may be that there was residual disease study, maybe the first one, but I would very much hope that, and I'm sure they will work together. And I think that once we have the more individualized treatment approaches, which Giuseppe mentioned, with the different biomarkers, then for those groups of patients, because the numbers in Europe and the numbers in the States are small, we will work together. So the next question is, again, on collaboration successes. Why is the INRG so important, and what do you see as the outcomes of this? And the INRG now is about 12 years old, and I think the greatest success and importance of the INRG is international collaboration, because that, I mean, the INRG has brought together Japan, Australia, US and Europe in a much more effective way. And again, about 3 weeks ago, Julie Parks have mentioned that in one of her talks. And there's a lot of other benefits. We are starting to understand the different groups which require different treatment, so we know exactly which groups require intense treatment, which groups require less intense treatment, much more than we did in the past. So some children, 10 years ago were over-treated, some children were under-treatment. We're getting much more focused. We understand how neuroblastoma in adolescence behaves. We understand about the behavior of ganglion neuroblastomas. So these are some things we've learned, and I'll give more examples in the next couple of slides. But I think the current challenge, which is more difficult, is we've got to get genomics incorporated, because there are a lot of now genomic work being done in a large number of leading labs, and we've got to get this into the INRG really to give the maximal benefit. So these next 3 slides just illustrate the studies that have resulted from the INRG, a different one. So these are 3 full slides of different studies. One important one looked at the actual relapse, the frequency of relapse, and these there are numerous studies that have originated and helped us understand about neuroblastoma and HELPS therapy, which if we had done either as Siap or GPOH or COG, we wouldn't have got the answer. So that's been a major success in collaboration. So the final question on the first section is, what have been the biggest successes in the past 10 years from the study groups in supportive care? So my take is that there's 4 types of big step forward in the last 10 years. The first of all, in intensive therapy, we've shown that intensive therapy has some benefit. The second step is immunotherapy, and to show from Alice Yu's work of anti-GD2, and then Holger's work really to emphasize that actually the benefits, probably there are not major benefits of GM-CSF and IL-2, and also you can deliver GD2 with less toxicity and equal efficacy in the long-term infusion study. We've shown the superiority of busulfan and melphalan. COG have now shown the superiority of the tandem high-dose therapy. I think there was a lot of potential now in chemotherapy and immunotherapy. I hope we won't be disappointed. I have been disappointed over the last 40 years. I remember Australia presenting some unbelievably good results with high-dose therapy about 1993, which didn't mature. But I hope that the results that Wayne and Rajan Moody have presented will transfer into more children being cured. The third success, as we talked about before, is more international collaboration. And the 5th success is we're identifying more the immunotherapy targets and the drug targets. Now, I know Pam Cairns and a numbers have talked about randomized trials, but just to emphasize a bit more about randomized trials. And there are pitfalls, and I think that pediatric oncologists should have humility, because we cannot accurately predict. We think we know what's going to be the best treatment, but so often we're wrong. And it's the randomized trials that show us that. And over the last 40 years, the number of times I've seen a new drug or new combinations looking really exciting, and we think this is going to make a major difference. And 40 years later, it hasn't. So, and that also, paradoxically, if you give more treatment, you may not always cure more children. You may actually cure less children. So life is really complicated, and randomized trials, as Pam Cairns said yesterday, help us get through that difficulties. And it's really difficult or impossible to compare what's best with what happened 5 years ago, because we've got better surgery, better supportive care. So I think randomized trials are really important, but I think that we can do things better. We can do randomized trials on smaller number of patients, not 300 patients, but less number of patients. We can also stop a trial if the survival curves are going to be identical and there's going to be no benefit, and by using futility rules. So I think in the past we've probably gone on for too long. And finally, it's important to do the opposite. When something looks good, we've got to be sure that it stands up to long-term analysis. So next we'll move on to the question about neuroblastoma. And the questions here are, what causes neuroblastoma? Is it because an immature embryonal neural crest failed to mature into benign neurons like they should? Then what causes that? Is it a catastrophic event? Is it epigenetics? Now, I know that Nikon and the panel yesterday discussed it briefly, but just some take-home messages about this, that I think what we understand now is that in the developing fetus, there normally is an increased number of neurogenic cells. And they're at the back of the chest and the abdomen, and they normally decrease in number, but for some reason, these neuroblastoma cells don't decrease, but increase and may result in neuroblastoma tumors. And we increasingly know about the genes responsible for this, and we're getting a better idea. And then the paradoxical thing is, but some of these neuroblastomas, as we know, are not destined to be neuroblastomas that kill children, but ones that disappear or become benign. So I think, and please let the experts also add into this, I think at the current time there's no evidence that environment factors are a major difference, but there are differences in part of the world. I don't think there's any evidence that anything happened during pregnancy could contribute or cause the development of neuroblastoma. There's a lot of research taking part in this area. And there is a very small percentage of neuroblastomas that are caused by familial genetic factors. And there is some work done by Sue Cohen to say there are racial differences. So I think we are paradoxically more advanced in treating neuroblastoma than understanding the cause of the neuroblastoma. The second question about neuroblastoma is, if this is an embryonal tumor, why do some children get diagnosed later at 5, 10, and beyond years? And I think the simple answer to that is that probably these tumors are maturing, but some of the cells become aggressive. And one group of this is the nodular ganglion neuroblastoma. And often these tumors have the A2X gene, which Nikon showed very spectacularly a few years ago that teenage neuroblastoma is associated with this gene. So the third group, the third of four groups, is the immediate future. Now, again, put some of my personal views on it. I think of the three things that are around for newly diagnosed patients, what has the greatest potential, and they may, as I said before, they may not turn out to be helpful, but the potential value. And I think the combination of chemotherapy and immunotherapy at presentation. Secondly, the double high-dose therapy, and thirdly, vaccines. So those are the things that I think that we need to evaluate and potentially get to all children at neuroblastoma as fast as possible. And I think the challenge is to introduce these treatments quickly into clinical trials. So the questions in this group are, why aren't there more targeted therapies for neuroblastoma? So again, this builds on other talks. I mean, first of all, the neuroblastoma is a tumor that has benefited, and children with neuroblastoma have benefited exceptionally because GD2 is a very definite immunological target. And as we've heard this morning, there are new immunological targets. Looking at the molecular targets, I think that these are not all straightforward targets. MICN, all the drug discovery experts, work pharmaceutical companies, everyone agrees it's very challenging to drug MICN. But now we've got a number of potentials, CDK9, 7, BRD4, mTOR, polyamine pathway, aurora kinase with the ATR inhibitors, are all strategies to target MICN. Some of those are in clinic now, others we need to get into clinic as quickly as possible. Anaplastic large cell lymphoma, ALK, I mean, when it was first discovered, we felt this was a great way forward and a great potential. However, in neuroblastoma, it makes it harder than other cancers. ALK in lung cancer and in anaplastic large cell lymphoma in children and inflammatory myoblastic fibroblastic tumor in children. All of those respond to 5 of the first or second generation ALK inhibitors. However, if you give those same drugs to neuroblastoma, the response rates you get are not 80%, which you do with the lymphoma, but more like 10 or 15 or 20%. So that it is much more challenging, and the hope, as Lou Chesler said, and a lot of his work goes toward it, hopefully a third generation ALK inhibitor, laratinib, or combinations will overcome it. I think probably the lowest hanging fruit in terms of target, paradoxically, is MEK inhibitors, which Giuseppe mentioned early on, and because the drugs have been developed for adult cancers, they're finishing evaluation in children, and we know the population of tumours that have abnormalities of RAS pathway are those that should respond to MEK inhibitors. So that's the one that actually is probably the lowest hanging fruit. P53, another target, the pharmaceutical industry have found it very difficult to target for adults, but drugs are about to come. And then you've got ATRX and TERT, which are definite targets for neuroblastoma, and they are just very challenging to drug. And more research is ongoing at the moment. So I think the reason there aren't more targeted drugs available is that the neuroblastoma is a difficult tumour, and compared to even some adult cancers, I mean, compared to lung cancer, which historically had always a bad prognosis, lung cancer is a much more easier tumour to target with molecular drugs than neuroblastoma. And then we come to PD-L1, and when PD-L1 inhibitors first were introduced into adults, they had revolutionised the scene, and we thought the same would happen to children. And unfortunately, for pediatric tumours, as Holger mentioned, the responses are very low. And therefore, we need strategies to make tumours more responsive to PD-L1 inhibitors. So the next question is, why are relapsed and refractory children always lumped together? And I think we've done this historically because we wanted to have the least number of trials, so that because the trials are, we want to open as quickly as possible, so we lumped this group of patients together. But increasingly, we are developing specific trials for the treatment of refractory or relapsed patients, and Veritas currently is going to be purely for refractory patients. So I think it's a historical thing, but I think now, especially because we're getting bigger groups together, we're going to be much more specific. So the next question about treatment is, are double stem cell transplants really the way to go in 2017 and beyond? And is there any chance that MIBG added to tandem will only add toxicity? So I think any doctor who's treated a child with neuroblastoma feel that a double cell transplant is not the way to go ideally because of the side effects. And we wish that it wasn't. But undoubtedly, the study led by Julie Park at COG has demonstrated that a double stem transplant does have a beneficial effect in terms of curing more children with neuroblastoma. So I think that we can't, that too many children are dying from neuroblastoma at the moment not to pursue any opportunity to cure the maximal number. But whoever wrote this question is totally right. There is a chance that MIBG will do nothing. It'll just add toxicity. But there is also a chance that it may add another 15% in cure rates. And if you're one of the children, that the 15% that would be cured, then I think it's definitely a chance worth taking. And just to note, it's 30 years now that MIBG, Rupert and I were talking last night, was first used. And we know it's active, but we don't know at the moment, will it cure more children? And hopefully, this study will help us answer that question. So the next question, what happens when a child with relapsed neuroblastoma is put back into remission after chemotherapy, either on Beacon or another study? What should be the next step? Surely wait and watch is just waiting for the disease to come back again. And so 1,000,000% agree waiting and watching is not the way forward, and we need to have options for treatment. And the Relapsed meeting that we had in Cambridge identified 6 options: minivan, which we've heard a lot about, biomarker trials, which Giuseppe mentioned, continue with chemotherapy, consolidation with MIBG, or consolidate with a haploidentical transplant, or continue with immunotherapy. And my hope and expectation is now that with GPOH and Siap together, we can actually get a much better pathway for these patients, much better clarity in what the options are, and we can also define what is the best option through trials for any individual trial. There'll be some children who will benefit best on biomarker trials. There'll be some who benefit much on haploidentical. And I think now that GPOH and Siap are together, I think this is one benefit I'm hopeful for. The next question is a longer question, but it's basically saying, if I can paraphrase it, that why haven't we got vaccines and DFMO available in Europe? Because children are still going to the US for these treatments. Now, I think there's 3 aspects to this. First of all, as Nick pointed out yesterday, although people are quoting different information on what is the chance of your child relapsing once they've finished immunotherapy, we haven't got that information very, very clear. And now that we've got the immunotherapy trials a bit more mature, we can generate that information, and I think that's the first step. The second step, which Nikon dealt with very well yesterday, is DFMO. And there's a lot of unanswered questions with DFMO. DFMO, I think, potentially is a drug that could help children with neuroblastoma a lot. All the preclinical work says that we need to give really high doses for it to work. And the current maintenance trial, it doesn't do that. And there is a lot of uncertainty in understanding what the data is coming out of the maintenance trial. And also, there are potential very good combinations for the future. So I think what we've talked about DFMO extensively. I know Daniel Morgenson came here and discussed it a couple of years ago. A lot of discussions, and I think that actually what we don't want to do is to start a trial with DFMO, which in a year's time we say we've got this totally wrong, and this is the wrong trial to do. And we've spent a lot of effort, I think, discussing this. And my personal view is that our effort should be put very clearly into vaccine and trying to introduce a vaccines at the present time and bring those very much to Europe. So the next question is, how close are we to genetic testing for all neuroblastoma patients and individualized medicine rather than the current one-size-fits-all? So both Lou's talk yesterday and Giuseppe's talk today have really answered this question. SMPs will open in 2018, and that will be molecular profiling of all patients. A vital component on the next European high-risk study is looking at the genomic investigations. So as well as the treatment aspects, that really getting the biopsies, getting the blood samples for circulating the DNA is essential. Your role in helping and in encouraging biopsy to relapse is really important. So I think with that, we'll be able to have a genetic profile, and then we can do other tests once we've got on the material to look at the immunological profile. And then we need good targeted drugs, really, as Giuseppe said a few minutes ago, to lock the appropriate locks, because there's no point trying to unlock the wrong lock. So I think that our aim is, neuroblastoma is multiple diseases. We need to do tumor profiling and characterization, and then appropriate targeted therapy. So definitely next year, I think a large amount of Europe will be able to profile neuroblastoma patients. The next question, which we've touched on yesterday, is this controversy, as Nikon said, between MSK and Siap and COG. So the question is, as MSK survival rate without stem cell transplant and high dose are the same as with, why do Siap and COG still do it? So basically, Siap and Cog, we feel that too many children are dying from neuroblastoma at the moment. We want to give as much treatment. So once we've cured, in 95% of children with neuroblastoma, then we can start to actually de-escalate. 3 studies have shown that high-dose therapy does improve outcome by 10 to 15%. And therefore, Siap and Cog believes that although toxicity is significant, we don't want to reduce therapy at a present time. We think that it would be awful if we stopped using high-dose therapy and there are some children who currently were cured were no longer cured. On that point, right, good. So this is, again, a very important question, but it's quite a long one, and I've even abbreviated it to what I want. So the bottom line is, I think that, when families bring up a discussion about treatments, that some parents experience a lack of enthusiasm from the child's clinicians. So it's this balance, new unproven trials versus hope and readiness to try and is almost like talking different languages. How can we bridge this gap and create a system to work while being acceptable to clinicians and families? So I think that's an adequate paraphrase. So I think, first of all, that patients should have a range of options in therapy. At the time of relapse, that there is no right treatment. It's up to the patient and the parent in discussion to actually find out what is right for that child. I think that we need to bring more options to the UK, and if the options aren't here, the child should go to where the options are. I have 3 hopes for the future. I mean, first of all, solving kids' cancer action plan. And taking those, it says facilitate access to the best available treatments and most promising clinical trials, support and enable best-in-class clinical research accessible in the UK. So I think if Solving Kids Cancer follow that, which I'm sure knowing the trustees and the CEO will do, that will help this dilemma. Secondly, I believe that the common relapse approach, which is being developed by the Siap and GPH first in the meeting in Cambridge, will help towards it. And thirdly, I think Helen Pearson's research will help. So I hope this reluctance of some physicians to help parents and look out for novel therapies will become less of a problem with these 3 initiatives. So now we're left on the 2 final general questions. What would you consider a cure for cancer like neuroblastoma, and how far away do you think we are from that point? So the cure for neuroblastoma is very simple, that all children with neuroblastoma are cured, and not that they die at 6 years after diagnosis, but using when I was working with patients, I define cure is dying of old age. And that's what we want for children with neuroblastoma. So virtually identical to Nai Kung, who said that when 30 years ago, he knew no survivor of stage 4 neuroblastoma over the age of 18 months. In 1987, when we developed Kojak, no child in the north of England again survived with stage 4 neuroblastoma. So progress has been made, but I think the progress is far, far too little and much more needed. We won't have one major step. We'll have continued other steps of 10 to 15%. And I think that greater understanding on the types of drugs, applying some of the technologies that are being applied now to adult cancers will help us to do this. And then the $50 million question, which I've left to last. What would I do tomorrow to help children with neuroblastoma if somebody came along and handed you £100 million and told you to get on with it? And I'm going to ask each of the panel members the same question, so you've got about 5 minutes to think of the answer. So I think that you need to use the money wisely and get the maximal quickest benefit. So I mean, if you use the money really to do very detailed laboratory research, that probably would help children with neuroblastoma in 10 years' time. But I think we need to do it, bring it a bit quicker. And that my perspective from my retirement is that there are a lot of ideas of how children with neuroblastoma more of them could be cured. I mean, you know, the presentations we've had over the last few days identify this. The problem is that we are not getting those ideas as quickly as I would like us to the children. So what I would do would I'd invest dramatically in clinical trials. I mean, Pam Kent yesterday showed a picture of the clinical trials unit in Birmingham. If it was the pharmaceutical industry and they were running the same number of trials, they would have at least 5 times the number of people, because they have the funding to do that. Pam agrees totally. You know, the money that she has is from CRUK and other charities. And if you have more people, then you actually can deliver your clinical trials quicker. I would also fund clinicians, and this is a bit more complicated to understand, but I'd fund clinicians who have the ability to help children with neuroblastoma by developing new clinical trials, but they're limited to do so by their duties. And looking around Europe, there's a lot of people who have really good ideas, who are really hardworking, right? But they are employed by a hospital, and that hospital says you have to actually do this and this and that to get your salary to look after your family. Someone said to me yesterday, it's almost doing the work that's going to help children with neuroblastoma in the long term is a hobby. They have to do it out of hours. And even if they do it out of hours, they're limited because you've got to sleep. So I think that definitely if you funded clinicians to do clinical trials and clinical research, you would help children. I think that there should be investment in neuroblastoma laboratories and to link them more in Europe. I know the European scene much better than I do the States. I know the States well. There's a lot of really good laboratories who got a lot of good ideas, and we just need to help them and link them more. And finally, I think fund drug development. There already are 2 organizations internationally that I mentioned a few minutes ago that want to fund drugs that actually are not commercially interesting. But I think that actually the 100 million, if it had any money left over, I'd put into that. So I've covered as many questions as I could. I hope I've got time for a few questions before we move on. Thank you very much indeed.